So just to make sure that we don't misunderstand each other, I was not arguing that you should leave HIV untreated and therefore progress to low CD4 cell count. I was actually talking about allowing people not to progress below 350. Most of the data that you showed of harm from untreated HIV, and you're correct, because I've been generating much of the data, so I should know, actually pertains to excess harm for untreated HIV if you do allow HIV to progress to less than 350. But that's really not the discussion here, okay? The discussion is whether we should treat HIV in early disease. So I wanted to make sure that I clarify that specifically. The other point, I just to pick up on your your conclusion chart, you said there's no reason to doubt efficacy of treatment as prevention, as there's no doubt to use condom use, and you are correct. As a matter of fact, I also agree that if you put people on treatment, they are less infectious. I think I actually was trying to make that very clear. So I'm not disagreeing about that. That's not my point. My point is just that we want to make sure, as physicians, that if we put people on treatment, that they stand to benefit themselves from putting them on treatment. That's really the only point I'm making. And it's not because I invented first do no harm. It's actually something that has been true in medicine for thousands of years. So although I appreciate the acknowledgement that that's really not my idea, I'm just trying to adhere to it in my practice, which was the argument I was trying to make. Yeah, the last thing, if I can just be allowed to show this slide, is that in terms of whether HIV in early HIV, whether antiviral treatment in early HIV works, I put together this slide because I put together some of the statements that we have made in conferences such as this in the last 15 years. Sadovudine monotherapy should be used in early HIV disease. We're back in 1991, for those who remember that. ART should be deferred to CD4 less than 200. ART interruptions are healthy. D4T and DDI is an atoxic combination of ARVs. IL-2 should be provided to well-suppressed patients remaining with a low CD4 cell count. That was actually used as standard of care in France over a couple of year period until we realized that the CD4 cells induced by IL-2 didn't work. Tenofovir does not adversely affect kidney function. I can put you many quotes on that. Atazanavir, ritonavir, causes no other adverse drug reactions that increase levels of bilirubin. So the point I'm trying to make is that there is expert opinion, and this has been a hallmark of HIV medicine, and it has been that for many years. But I think these errors in statements has been rectified by continued research, and therefore I would like to see that research is leading to policy change as opposed to policy change is impacting on the research. So I put this slide not because anybody should feel that they are portrayed themselves. It's obviously a picture of lemlings. Lemlings which have a leader that claims a certain statement, and the rest of the crowd actually moves along in that direction. Obviously, it will, in this instance, be quite futile given the fact they all go over the cliff. So we need to discuss who is the expert there who's telling all the lemlings to run over the cliff because they obviously is doing harm to themselves. This was a joke for those who should feel that I'm overstepping my boundaries. This was meant to be a joke and nothing more than that. Thank you very much.